Thank you, Congressman. I'm David Himmelstein. I'm a primary care doctor in Cambridge, Massachusetts, and an associate professor at Harvard Medical School. Some of you may ask, why is he dragging a Johnny up here? It's symbolic of our Massachusetts plan. I want to tell you that, like a hospital Johnny, it looks a lot like coverage until you start to inspect carefully around the back. When I first came to Harvard, they told me an expert is anyone who comes from out of town and brings along their slides. We don't do slides anymore, we do PowerPoint, so you'll excuse me for showing you this. I'm going to give a little background to the reform and some of the data that we have, which is at this point only fairly scant data because it's a new reform. But let me set some of the background here. First, the problem that we have to deal with in our healthcare system, well illustrated in this slide, which never goes out of date, and the rising costs of healthcare. Professor MacEwan, my tutor in economics, tells me you can illustrate any point in economics with it. If you flip it upside down, it's the GDP. We have rising costs at unsustainable rates in Massachusetts as elsewhere. The second problem that I ask you to keep in mind is the enormous number of people who have problem affording care. Donna Smith has talked about her bankruptcies. She's not alone. 3/4 of Americans who are bankrupted by medical care had insurance, at least when they first got sick. And that remains an unsolved problem, maybe a worse problem in Massachusetts than before. Third is we deliver large volumes of care that do patients no good because there are financial incentives. This is data from the RAND Corporation showing that 41%, for instance, of the hysterectomies are either clearly unnecessary or of very questionable necessity. And for a variety of medical procedures, we have that kind of data. So, and the fourth point is that as we've tried to limit care, what we've done is hire more and more people to tell us what not to do as clinicians. The yellow on this slide is the number of physicians in our healthcare system, and the blue is the number of bureaucrats, by far the fastest growing element of our healthcare system. And fifth is that we already spend so much in this country, we ought to be able to provide superb care to everybody in our nation. The yellow on the US bar there is our per person spending in public dollars, and the point here is that we spend more in public dollars than any other nation on the face of the earth spends on its entire healthcare system. We already pay for national health insurance, but we don't get it. A commonplace, we have extraordinarily poor health statistics. I'll just skip through these. The yellow is the US poor life expectancy, high infant mortality, high maternal mortality. It's not that we spend a lot of time in the hospital, we don't compared to other nations. It's not that we get a lot of doctor care, we don't compared to other nations. It's not that we have so many nurses in our hospitals, we have fewer than most other nations per capita. It's not that we use more technology in many respects. So just one example, we do fewer bone marrow transplants per capita than many nations that spend far less. What we get a great deal of is bureaucracy. About 40% of the difference between us and Canada in spending is pure bureaucratic cost. And here per capita on hospital billing costs, so Mass General has 352 people in its billing department, and Toronto General, same size hospital, 3 people in its billing department, because they get paid like a fire department does. They get 1 check a week for their entire operation and don't have to bill individual patients. My group practice, we pay 10% of our gross receipts for a billing service. That's in addition to my efforts and my secretary's efforts, and that's extraordinarily costly. Canadian doctors don't face that, and insurance companies, my personal favorite is Jack Rowe, who left, fine geriatrician, ran our geriatrics division at Harvard for years, moved to Aetna, where he made $225,000 each day while he was at Aetna. We couldn't compete with that as a salary. Well, brings me to the reform that we have in Massachusetts, and you might ask, why am I showing Richard Nixon's picture here? It's because its actual origins are in Richard Nixon's health plan, a plan he offered to try and block Senator Kennedy's national health insurance program in 1971. And he proposed that government use its coercive power to make people buy private insurance. He proposed an expanded Medicaid-like program which would be free for the poor with subsidies for those just above the poverty level, with a buy-in for others to this quasi-public program, and a mandate that employers provide some coverage for their workers, and what he called managed care as a strategy for cost containment. Now we've moved from that to the cost containment in Massachusetts was supposed to be care management. But other than that, we have in many respects what Nixon proposed. What's new is not just the employer mandate that employers have to contribute, but individuals are required to buy coverage for themselves. Promised cost savings through computerization is new. We have no evidence whatsoever that that actually works, and considerable evidence that it doesn't, and that the government should provide a brokerage function for these private plans. Now, George Bush comes into the picture because he pushed the Massachusetts plan by saying that the $385 million that was going to safety net institutions in our state would no longer be allowed to be paid to them out of Medicaid money, that the state had to go to an insurance mechanism, which in effect would take much of that money away from the safety net hospitals and clinics like the one I work at. I'll return very briefly to that. In Massachusetts, we have that basic Nixon plan. The poor are in a Medicaid HMO, or a program very much like it. Those between 100 and 300% of poverty have partial subsidy under a public program, and of those 300%, it's a buy-your-own kind of program, but you're required to. We now have a fine of $1,000 for being uninsured in our state, and just the point here, you can beat your wife or husband and only face a $1,000 fine. But uninsurance is as serious an offense as drunk driving or spousal abuse. For someone my age, the required coverage costs at least $4,800 per year, with a $2,000 deductible before even a penny of bills are covered, and 20% co-payment after that. So if I were to have this coverage rather than my employer coverage, I would pay $6,800 out of pocket before I got a penny of coverage, and have 20% of my bills to bear after that. The number of uninsured has fallen. There are a variety of surveys, and I won't belabor them. Best estimate is about half of the uninsured have gotten coverage in the state since this program was passed. Now, that sounds pretty good. The left-hand pie there is the poor. About 95% of them have gotten subsidized coverage or free coverage. Among the near poor in the middle there, we know that 23% have been signed up for the partial subsidy under the state program. We don't know what's happened to the rest, but we know many of them remain uninsured. And among those over 300% of poverty, only 7% now covered under the public plan. We no longer are growing our insurance coverage in Massachusetts. The reform has plateaued. So as you go to the right here, you're going to more recent data, and the number enrolled in these subsidized plans is actually going down. And here I've brought it up through February of 2009, and you see we continue to have a fall in the number of people covered. And the yellow line is the unemployed rate in our state. So we've had 85,000 new unemployed in our state, but no growth in the number of people being covered in this subsidized coverage. So while we don't have survey data, we know there are rising numbers of uninsured again in our state.